So our first topic, that is the arrangement of spinal nerve. So here we are. Basically, this is a cross section of the spinal cord at the T1 level. So it consists of two outcomings or outlets, that is dorsal root and ventral nerve root. Dorsal nerve root is sensory and ventral nerve root is motor. And dorsal nerve root consists of dorsal root ganglion. Ventral nerve root consists of motor nerve roots, and these two combine to form the nerve trunk. Then further, this nerve trunk divides into a dorsal ramus and a ventral ramus. So the dorsal ramus and the ventral ramus further consist of both sensory as well as motor nerves. Now it also has white and gray rami communicants for the arrangement of sympathetic system, that is consisting of preganglionic and postganglionic sympathetic fibers. So when we take a look at the brachial plexus, first of all we have to understand the tree, that is the uh, now when we take a look at the tree, so tree consists of underground roots, main trunk, and further divisions, cords and branches. Similar is the brachial plexus. The brachial plexus is one of the important plexus of the upper limb, which supplies the structures of the upper limb, that is the muscles and other structures. So it is formed by nerve roots C5 to T1, that is C5, C6, C7, C8, T1, ventral primary rami. So taking a look at the brachial plexus, as we have seen that it is formed by ventral primary rami of C5 to T1 nerve roots. It also may consist of the contribution from C4 or T2 nerve root, resulting in prefixed or postfixed plexus. In a prefixed plexus, the contribution by C4 is major and by the T2 is absent, and in case of postfixed plexus, the contribution by T2 is major and by C4 is absent and by C5 is reduced. Now, these nerve roots further align to form trunks. The nerve roots C5 and C6 combine to form the upper trunk, C7 middle trunk, C8 and T1 the lower trunk. Now these trunks further divide into ventral and dorsal divisions, that is all the three trunks. These divisions accordingly combine to form the different cords, and these are lateral cord, medial cord and posterior cord. Now the lateral cord is formed by the ventral division of upper and middle trunk, and the medial cord is formed by the ventral division of only the lower trunk, and posterior cord is formed by the dorsal divisions of upper, middle and lower trunk. Now these cords further give out fruits, that is branches, and the branches are from the lateral cord, lateral pectoral nerve, musculocutaneous nerve, lateral root of median nerve. And for the medial nerve, we can remember it in the form of a mnemonic, that is M4U. M stands for medial root of median nerve, and it is for medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial pectoral nerve, and this is the ulnar nerve. And the posterior cord has its branches basically in the form of ulnar, that is the mnemonic is U. Actually U stands for upper subscapular nerve, L stands for lower subscapular nerve, N stands for nerve 2 latissimus dorsi, A stands for axillary nerve, R stands for radial nerve. So here we complete our brachial plexus. So brachial plexus now has some clinical abnormalities or some clinical part attached to it, which is very important with the point of view of exam. So we are going to discuss it. So once you complete the brachial plexus, you can easily understand the nerve root value. If we talk of these three branches from lateral cord, it will consist of nerve root value C5, C6, C7. Now we are going to take a look at the clinical anatomy related to brachial plexus. Uh, First of all, it's Erb's paralysis. Erb's paralysis is basically an injury to the upper trunk at a particular point that is known as Erb's point. Now, Erb's point consists of 6 nerves, incoming or outgoing, whatever you understand it. So, it consists of the nerve roots from C5 and C6. This one is the subscapular nerve, and this one is the nerve to subclavius, and this is the ventral and dorsal divisions. So, injury at this point may be due to any of the following reasons, like due to birth injury, or falling on the outstretched shoulder, or it may be due to anesthesia. So, the consequences of the injury will be resulting in Erb's paralysis. Now, the muscles paralyzed or involved in that case would be biceps brachii, supinator, and infraspinatus, supraspinatus, and some other muscles close to the scapula and shoulder joint region. So the actions hampered due to this paralysis would be that first of all the individual who has undergone through that injury, his hand will be, or his entire upper limb will be in a particular position, struck in a position, that is he won't be able to flex his forearm, neither adduct his arm, and it will be in a medial rotated manner, and so this position is ultimately called as waiter's hand, porter's tip hand, or policeman's hand. So now the next anomaly or clinical anat part related to brachial plexus is clump case paralysis. In case of clump case paralysis, the lower trunk is injured. Basically, the injury may be due to the sudden outstretch or abduction of the hand in case of falling from a height. So you're trying to clench anything. So in that case, clump case paralysis occurs due to the injury to the lower nerve, lower trunk. So the features associated with clump case paralysis is first of all, the ulnar flexors of the wrist and the fingers would be hampered, and then the intrinsic muscles of the hand, because the nerve root C8 and T1 are involved. Now, the actions involved due to this paralysis are firstly, the person won't be able to clear his hand. The hand would be struck in a, or the palm would be struck in a claw hand position due to unopposed action of the flexors and extensors. So there is hyperextension at metacarpophalangeal joint and hyperflexion or simply flexion at interphalangeal joints. Now there is also sensory loss in a strip along the ulnar border throughout the forearm, and some other symptoms if the nerve root is paralyzed or injured in a particular manner prior to the prior to a particular point or white ramus communicans, then some other symptoms or signs near the eye would be observed, like there will be ptosis, meiosis, and loss of ciliospinal reflex. That is, the eye won't be able to accommodate for far and nearby vision, and also there will be anophthalmos. That is, the eye would sunk deep into the orbit, and so these symptoms appear in case of clump case paralysis due to the injury to the lower trunk consisting of C8 and T1 nerve root. Now, there is another condition, that is nerve to serratus anterior is damaged, and it particularly happens in case if the shoulder is in case if a large pressure is created on the shoulder from above, or due to carrying some heavy weights on the shoulder. So in that case, the nerve to serratus anterior gets paralyzed and serratus anterior muscle is paralyzed. So if at once serratus anterior muscle is paralyzed, it will lead to medial border winging of scapula. That is, simply the medial border of scapula gets prominent and the pushing and punching actions are hampered. So in case of pushing or punching, the scapula elevates medially, and so it will ultimately lead to further problems, like the person cannot abduct his arm above 90 degree. Okay, so thank you for watching my video on brachial plexus and nerve roots injury leading to ERBS paralysis and clump case paralysis